Hi, it's Ashlyn Smith, PA and founder of Elm Endocrinology and Lifestyle Medicine in Arizona, back to talk with you more about type 1 diabetes. I know I'm not alone when I say it is so heartbreaking when one of our patients who previously had no idea they had type 1 diabetes ended up in the emergency room with life-threatening diabetic ketoacidosis. But it's also encouraging to know that we as PAs can be a big part of helping individuals get diagnosed earlier before they end up with such an extreme manifestation. In this video, we're going to talk about the staging of type 1 diabetes, and in the next, we are going to apply our knowledge of pathophysiology and stages to think about who we should be screening and how, so that we can get ahead of DKA and other complications that come from delayed diagnosis. In 2015, JDRF, which is now Breakthrough T1D, Endocrine Society, and ADA came together to provide a staging framework for type 1 diabetes. They defined 3 stages in which autoimmunity is present and the disease progresses as beta cell mass and function decline. Before we get into the stages, we need to understand that there are 4 main autoantibodies associated with type 1 diabetes: GAD autoantibody, islet cell antibody, IA2A, and zinc transporter autoantibody. Insulin autoantibody can be used as a screening for T1D before insulin therapy has begun, but it is unreliable once someone has started on insulin. These autoantibodies can be detected with simple blood tests, which we will discuss in our next video. Right now, they are important for us to know because the number of autoantibodies correlates with risk and helps us understand a patient's type 1 diabetes stage. They can appear months to years before clinical symptoms appear, so screening allows us to detect them early to get ahead of clinical disease. As I mentioned, there are 3 stages. In stage 1, 2 or more autoantibodies are present and beta cells are already under attack. But glucose assessments are normal and the patient is not exhibiting any symptoms. In stage 2, there are 2 or more autoantibodies, beta cell mass and function are now declining, and as such, insulin production and glucose homeostasis are impacted, resulting in abnormal glucose. However, the patient is not showing any symptoms and the glucose levels do not reach the level of clinical diabetes. In stage 3, 2 or more autoantibodies are present, beta cell mass and function have significantly declined, and the patient has elevated glucose at the level of clinical diabetes. They may exhibit some of the typical manifestations of diabetes, including polyuria, polydipsia, weight loss, fatigue, and even DKA. When we catch T1D early, PAs can educate, refer, and plan with patients to prepare for clinical disease. For a patient with stage 1, the risk of developing symptomatic diabetes within 5 years is about 44%. And for a patient with stage 2, the risk increases to about 75%. For both stage 1 and stage 2 type 1 diabetes, the lifetime risk of developing clinical diabetes is considered 100%. Staging gives us as PAs the opportunity to lay a foundation of education long before our patient develops critical disease. We can teach patients what to look out for as their disease progresses, monitor glucose more closely, and ideally reduce the risk of DKA with early awareness and patient empowerment to look out for concerning symptoms. And finally, staging lets us identify appropriate treatments or clinical trial options. We're going to talk a little bit more about this in my 4th video. So who is it that we are staging? How do we catch diabetes before it becomes symptomatic? In our next video, we are going to discuss screening, the who, how, when, and why. This is a very important one, so I hope you'll join me.